So I'm Dr. Julian Redhead. I'm an A&E consultant and chair of the London board of the Royal College of Emergency Medicine.
And you have in front of you volume 5, your submission. Can you confirm it's true to the best of your knowledge and understanding and that you wish it to stand as your evidence to this commission?
Yes.
Can I just ask you to clarify whether or not that is your view or whether that's a view endorsed by other colleagues in the Royal College of Emergency Medicine?
It's a view taken from a number of colleagues across the speciality, across London, but also nationally.
Thank you. Now, we know that shaping a healthier future is predicated on out-of-hospital services and community services being able to reduce the need for acute services. Now, bearing in mind the view that you set out, and what you say is that patients will continue to need the expertise of the emergency departments in any event, can you help with the extent to which improvement in community services, even if achieved as intended, will actually reduce the need for emergency care?
I think you have to look at emergency care as one part of a whole pathway, and that's both the patient coming to the A&E department, but also the flow through the A&E department into the main hospital and then out of the hospital as well. So the A&E is like a barometer of a system-wide changes which occur. So any change in the primary care or the community care will have an effect on the A&E department, either through earlier discharge of patients from the hospital, but also in terms of patients who will present to the hospital. So for me, for us in terms of the situation with community care, if you improve the community care services, you will inevitably have an effect on the A&E department, either in terms of being able to move patients out of the hospital quicker, which helps the flow of patients into the hospital from A&E, or indeed by reducing the number of patients who need to attend accident emergency.
I wonder if you could look, there's a volume 2, and if you could look please at page 581, and what this is a letter from the commissioning, the clinical commissioning group, and it is the Hounslow one, but really it's just by way of example. And what I wanted to ask you is this: it sets out various initiatives, such as social work and GPs co-working, GP weekend visits at care homes, community heart failure units and diabetes services. What I wanted to know is this, is whether you think those are the right type of services to put in place to best achieve the desired reduction.
Probably slightly difficult to read a whole document to say whether that's a complete list of all the different types of services. The ones that you've read out are certainly ones I would expect to see on that list, and certainly there is evidence from different parts of the NHS where those individual pilots have helped have produced changes in how emergency care is delivered in their local environments. And that's both from nationally and internationally as well. So they're the kind of things you'd expect to see on those lists. In the UK, I'm not aware where population changes have occurred such to allow all of these factors to be placed into one population to see what the effect is. And there's more evidence that comes from the United States around that type of population management.
If those services are the right kind of services, how do we test to see if they're delivering what they're supposed to be delivering?
Well, I think I was listening to the questions before around sort of pilots and things like this, and certainly pilots are an established method as to whether a certain system will work. And the trouble being is how big and how long you want that pilot to work to produce the statistical evidence that you require to say whether something is proved or not. And so the difficulty is the changes from each of those little parts will be small, but together your hope is that they will make a big change. But you need to have a big enough population studied over a long enough period of time to make sure that you're not having unintended consequences. So pilots are tricky things sometimes when you're talking about population management, and you need to look at evidence from elsewhere as well.
So how do we establish a firm evidential basis, which I presume you're saying is necessary before you roll out these services on anything other than a pilot level?
I think you need to look internationally, and you need to make some assumptions within your modelling, but your modelling needs to take into account all of those different factors and an error factor, because you won't have the ability necessarily to have established evidence of the changes that will occur.
And if that isn't done, if there isn't a sufficiently robust evidential basis, what is the likely impact of rolling out services without that?
If your modelling is incorrect, then there is the possibility that you will overload particular services. It could go the other direction. You've got an over-surplus of services in other areas. So you need to understand where the patients and the acuity of those patients that will move within a population, take into account national changes in population as well.
Now, if the out-of-hospital services don't materialise as fully or as quickly as the programme envisages, again, what then is the impact on emergency services?
Well, I think you would expect to see an increased use of those emergency services, and therefore more pressure being put upon the emergency services that are available.
And bearing in mind that some services will come under the umbrella of the out-of-hospital services under the umbrella of local authority provision rather than NHS provision, what if one element, perhaps the NHS element, but the local authority element, is not resourced or not sufficiently resourced? What's the impact then?
I think it largely depends on which element you're talking about. So some of these, as I said, will have effects on the ability to discharge patients from hospitals, and some will have an effect on the ability to move patients or the movement of patients into an emergency department. So each one will have a different effect and needs to be studied independently, but also look at how they interact as well.
So do I take it then that if there's a problem at the end, that's going to create a problem that pushes all the way back to the beginning?
Yes, most likely.
Can I ask you a little bit now about centralisation, because that's something you touch on. Now, obviously, the number of A&Es are being reduced under this proposal from 9 to 5 hospitals. Can you help with, other than the specific sort of trauma, cardiac and stroke services, what do you see are the advantages in centralisation?
Well, we have very good evidence base now around those services of trauma, hyperacute stroke and cardiac, that you improve outcomes and save patients' lives by ensuring that the patient gets to the correct hospital with the right backup services in the fastest possible time. And the previous system of taking patients to the local or the closest hospital did not have the same benefits to patients as taking them to a hospital which has the setup and the ability to deal with the care that they require.
What about for services, other emergencies other than those specific examples?
Okay, so evidence is less in those because they haven't happened. Those are the big ones which have happened both internationally and locally within London, and now occurring at a national level as well. You could hypothesise other emergency systems whereby an ambulance service can identify a particular subset of patients who would benefit from a more advanced approach to centralisation, and I would certainly expect those to be picked out to come together. The difficulty we have is in more general services, and the classic example would be general surgery, where you need to have surgeons who have experience based on the number of patients that will come through the door for a particular operation. If you're serving a population that doesn't deliver those number of patients to that number of surgeons, you can't sustain their workload and their ability to deliver care. Therefore, you need to centralise in those aspects to ensure that you've got enough patients coming through to give those surgeons the experience that they require to carry on improving outcomes for patients.
Now, in fact, you've highlighted as well, arising from that lack of availability of experienced staff is one of the reasons for centralisation. If staff availability wasn't an issue, would that impact on your view of the necessity for centralisation?
Well, it goes again in terms of the population. So you could say you've got an extra 100 surgeons coming into West London, but each individual one of those surgeons would therefore only operate on a very small number of patients, and therefore their experience and their ability to care for patients will be reduced. So it's not as simple as saying you need a large number of surgeons. You need to have the population to provide patients, I want a different way of expressing it, for them to build their ability to care for them.
And if there is an increasing population over and above that which has been estimated, does that in any way impact on that centralisation argument?
Well, the size of the population clearly influences the number of procedures and the types of procedures a surgeon would need to undertake. So a larger population most likely would support a larger number of surgeons across a healthcare and economy.
Now linked to that, you refer to the tariff system.
Yes.
I wonder if you could explain to us what that is.
Well, the way that the NHS within the secondary care is funded is through a tariff system, so that in the majority of cases there's various difficulties with it, but in a generalisation sort of sense, each patient that comes to your hospital carries a sum of money with them to pay for their care, which comes from the CCG. The trouble is these tariffs were set a number of years ago and were set in a maybe potentially slightly haphazard way, so that emergency medicine, where it's changing now to much more senior delivered care, so you're expecting consultants to be at this front door much more within 4 hours, the changes in 24-hour practice are all within that emergency department, and the tariffs haven't changed to reflect those services. So therefore it's very difficult for a trust to invest money in a department which is losing money for them in terms of the tariff that they receive for it. There's also the fact that across the whole board of acute medicine, the government set a target that said that you shouldn't increase your number of admissions over a threshold that was based about 4 or 5 years ago, and that they would basically took a 70% tax away from the hospital, so you only paid 30% of the tariff when you go over and above those thresholds of admissions. So the whole funding is very, very tricky in order to invest in your systems of emergency medicine.
And does that in itself have an impact on ability to provide and recruit and retain staff?
I think it depends on individual trust, but if you're always having to provide business cases which are going to lose money, the more staff you put in, then yes, it will have that effect.
I wonder if I could ask you just please to turn to page 1801, and this is a submission by Professor Pollock, who we're going to hear from later. And I just wanted to ask you very briefly about something that she says, and if you would comment on it.
Yes.
If you look at, sorry, bear with me a moment. At paragraphs 13 and 14, she touches on the tariff issue that you've just raised, and she talks about the 30% figure. And then at paragraph 14, she says the reduction in tariff is supposed to act as an incentive to hospitals to turn people away. The policy is not working, as patients unable to access their GP surgeries and out-of-hospital services are forced to turn to emergency departments. And then she goes on to comment on the other effects. Can you assist us? Do you have any comment on that analysis?
I think that the reduction in tariff, I think to say to turn patients away from A&E was not necessarily what the 30% marginal tariff was supposed to do. I think it was supposed to encourage hospitals and communities to work closer together to reduce the number of admissions. The trouble is that money didn't go to the CCGs, it was held centrally, the savings that came from the 7% marginal tax. So it hasn't necessarily had the effect that it was supposed to do, which was to ask the communities and the hospitals to work close together to try and reduce the number of admissions and to be able to use that money that was being saved through the marginal to come back into the system. But we haven't necessarily seen that happen.
So does that system need to be reformed or merely updated?
I think the way that we pay for emergency medicine needs to be reformed.
I wanted to ask you a little bit about the issue of urgent care centres and A&Es. Now, one of the major anxieties that seems to be a theme coming through is confusion over what an urgent care centre is and when someone should go to it. And as we know, there are proposals on foot for Ealing Hospital in Charing Cross to have on-site only an urgent care centre. First of all, can I ask you how you understand the definition of an urgent care centre?
I think it is a very difficult one, and it's difficult for the profession and therefore the public as well, I would agree. That the Royal College calls for co-location of urgent care centres together with emergency departments to try and avoid some of these issues. But we do know that around the country there are well-established urgent care centres which operate very well for their local communities. London has been potentially is different because it's an urban environment, and certainly when you go to communities outside of urban environments, they use their urgent care centres and they appear to be very successful in the way that they're used. So for me, urgent care is where those patients who don't require an ambulance, who would not require investigations over and above simple blood tests and x-rays. but it's more to do with the skill of who is going to be staffing the urgent care centres more than anything else, and that's not necessarily standard across the country. So some GPs, because they're quite a diverse population, will have great skills in how to manage certain situations, and some will have little exposure previously to that and will need more training and better skills in dealing with those. I think that's where the confusion comes from, is what skill level you're going to staff the nurses and the doctors working within those urgent care centres to provide care to the population.
And for this area, for North West London, what do you say, if any, are the risks of having urgent care centres which are not co-located with A&Es?
I think that the risks are, there's always the potential for a patient to go to the wrong area, and the one that would be quoted would be a mother with a young child running into an urgent care centre and the urgent care centre not being able to provide that help. The ambulance service in London are successful in providing category A services, and they do very well in their response rates to those. And that would be the response that you would expect to have, together with a large education programme. So I think so long as the urgent care centres have correct networks and good links back into the hospital, and the ambulance service understand how they're going to work in terms of patients who arrive who have increased need over and above those urgent care centres, then those risks can be minimised.
So do I take it that your support for non-co-located centres is predicated on there being an effective transfer system to A&E?
When it's required, yes. I think that would be one of the aspects that would need to be done, together with a population programme of education, so that people understand what services are provided in which locations.
So if that's lacking, if the transport infrastructure is lacking, does that not give rise to a greater risk?
I think if you said that the ambulance service were unable to cope and would not be able to provide the service to the urgent care centres in a timely manner, then yes, that would be a risk.
Are you able to help with what if any arrangements there are which are between urgent care centres, put in place between urgent care centres and A&Es, which don't involve blue light ambulance transport?
In terms of, this is...
If I give an example, a person turns up to an urgent care centre and is told, well, you need to go to an A&E, and either there isn't an ambulance available or it's not a condition that requires an ambulance. What is your understanding of what the transfer links are? How is it done? Usually those would be through public transport links, depending on the condition. And taxi services are other services that they can use. But those would be specific between different networks of urgent care centres and A&E departments, and I don't know all the different arrangements that are in place across London for that. But again, I presume, and you'll correct me if I'm wrong, that it would be important for those arrangements to be in place, for staff to understand what the arrangements were, and to be able to communicate that very quickly to patients.
Yes.
Can I just ask you to clarify, you've talked about level of staffing. Do you have a view about whether the urgent care centres need to be GP or consultant-led?
It depends on the population that you're expected to come. So if you were to say that it was going to be consultant-led in terms of A&E consultants within the urgent care centre, you're talking a very scarce resource already, in that we can't resource the A&E departments that we have, let alone resourcing urgent care centres as well. And the urgent care centres should be providing care to patients of a level where a general practitioner or an emergency nurse practitioner can provide that level of care. So I think that consultants may have an ability to go in there, as any consultant would, to work within the community to help within certain parameters, different conditions at certain times, in terms of clinics or reviews and things like this. But I wouldn't necessarily say that they would need to be there the whole time to provide that level of care.
Forgive me, I think, in fact, when I asked at the beginning of this section about what urgent care centres were actually to cover, I think you said quite simple conditions. I wonder if you could explain to us what they're not supposed to cover.
Well, I think they're not supposed to cover patients who are likely to require admission urgently into hospital. So those conditions where it is likely those patients can be cared for within the community. But there are certain, in order to make those decisions, sometimes you need additional investigations which an urgent care centre may not have, or the skills of a doctor where they may not have all those skills through their training. So we need to, it's a question of picking out those conditions where the patients can be seen by a general practitioner or by emergency nurse practitioners.
Is there not inherent in that a degree of patient self-selection that carries with it some risk?
Yes, and that's the reason for the good networks, to ensure that you can transfer patients rapidly when they require additional services which you can't provide in the urgent care centre.
Now, I just wanted to ask you a little bit about your views on the closure of Hammersmith and Central Middlesex Hospital's A&E in September 2014. You may not have the specific information, I don't know. Can you help us with what the impact has been on other accident and emergency services in the area?
I think this is it's a difficult one, because if you look at the national picture, the majority of trusts across the whole of England have struggled over that same period to maintain standards, and we've heard of hospitals going on to major incident alert and all these other factors across the whole of London, across the whole of the country, let alone across London. So to isolate off the effects of the Central Middlesex and Hammersmith closures within that are very difficult, because we've seen this across the whole of the UK. I think we have to rely on what modelling was done, and I don't know the details as to whether the modelling has been exceeded or not, according to the predictions they made about patient movements.
And if I were to say, as other witnesses have said, that the problems which occurred after the closure of those two departments impacted in a way which was over and above that seen in outside of the area, what impact would that have on your thinking?
Well, I think if you can prove that the impact has been greater in those hospitals affected by these two closures, then I would accept that's the case, and those departments have been under more pressure than has been seen at a national level.
And can you help us? Do you have any views about the wisdom or otherwise of the proposed changes, both in Ealing Hospital and Charing Cross Hospital, in terms of the reduction of acute beds?
Well, again, the reduction in acute beds will be modelled on the improvements in primary care, preventional medicine, and more community care. I haven't seen the evidence to know whether those are in place and whether they're having an effect. But you certainly want to see those have an effect before you remove the beds from the system.
Now, following on from that, the need to know if these things are going to work before you make more cuts effectively. Mm-hmm. You describe SAHF as ambitious. If steps are taken which turn out to be erroneous, how easy is it going to be to reverse them?
It depends on what they do. So if you close a ward, yes, then reopening a ward, I'm not saying it's easy, but it is possible to do in a shorter timescale. If it's to do with removing entire hospitals or entire infrastructure, then that will take more time if those things aren't available to be turned rapidly back round into wards if things go wrong.
Finally, I wanted to ask you, please, if you just have a look at page 1805. This is a Freedom of Information request about the consultation budget for this area. Mm-hmm. If you have a look at that, you'll see, and I have totted it up, and it comes to something over 13 million. Mm-hmm. Now, as an emergency clinician, do you have any observations about the size of that budget and the efficacy of it having been spent in that way? And if I say to you that this is a consultancy budget from February 2014, so it's over a fairly shortish period.
It's a difficult one for me to answer, because I don't know the details of exactly what they were doing and everything else. I mean, consultancies are used because they bring quick they quickly bring in resources which can help you build up cases and understand evidence which is there. I don't know what 13 million, whether that's a huge amount of money to be paying on consultancy. It sounds as a sort of lay member that's a large figure to pay on consultancy figures, but also I don't know exactly what work they were doing and how beneficial that work was to help the project move forward.
I wondered if perhaps you would be able to comment, and you may not be able to, whether or not you felt this might have been better spent on direct services. And perhaps there's an obvious answer to that, I don't know.
I mean, the obvious answer is I would say that clearly I want to see investment in the services because those are direct patient care. But I mean, I think you have to allow the fact that if you're going to make large changes to a system and you need to understand how those changes are going to affect people, and you believe that those changes are for the benefit of the population over a longer period of time, then you may consider that a small amount of money to pay.
Thank you. If you'd like to wait there may be some questions from the commissioners.
Thank you very much for your presentation. I'm going to be quick because we're a bit pressed for time. But I have a general question I want to ask you. We've been hearing evidence before today, obviously from other boroughs, but one of the things that's come across very strongly is the impact of fragmentation, which is very much geared to, if you like, the internal marketplace. So what is your view about how this affects emergency medicine? And I have another question linked to it, is because you began to define somebody who would not need emergency if they don't need an ambulance. Well, of course, I want to ask you, how do you define what amounts to emergency medicine? And who sets the criteria?
I understand. So in answer to your first question about fragmentation, and I assume you mean by fragmentation the breaking up into CCGs and into independent services of trusts and things like that.
Yes.
I mean, I suppose when I was young and growing up, the NHS was more unified and you could go to various parts of it, and now we are constrained in terms of budgets as to who cares for who across different systems. And my personal view, and I know the view of a number of doctors, is that we need to move back to more population management of illness rather than concentrating on institutions or on primary care or secondary care. And we need to look at how you fund healthcare across the population so that you can work across boundaries in a more beneficial way for patients. Does that answer your question about fragmentation?
Yes.
And then your second question was about sorry, I can't remember now what your second question was.
Well, the second question is a broad one. It may be difficult to answer it. I'm conscious of your evidence about pilot schemes, how long you go on and so on. But I'm also, therefore, if you can't do it that way because it takes too long and you don't know where the cut-off point is, then I want to go back to the beginning and say, well, how do you define emergency medicine? In other words, what are the criteria? Because some of the criteria we've seen are breathing difficulties, heart difficulties and so on. That takes you into emergency. So you began by saying, well, it's somebody who doesn't need an ambulance, doesn't need to go to emergency. But of course that may not be a correlation. So what are the criteria here?
I think this is one of the problems that people have had in terms of how you define what emergency medicine is, because you don't know, in a way, you have to turn that upside down and say you don't know who needed the emergency medicine until you know what the outcome of that patient was in terms of the condition that they actually suffered and what needs to happen to them. And I think this has been at the very heart of where the problems lie in terms of urgent care and emergency care and where those definitions lie. Because I would agree with you, it's not just who goes in an ambulance. Sometimes it's an easy one to go with because it's fairly clear somebody who comes by ambulance in general, but not always, has a higher acuity of care needs than a patient who arrives by foot, because by virtue of that they've been able to walk there. But obviously that's not true for every single patient, because we get a lot of patients who walk in having a heart attack who would certainly need to have emergency care and the talents of emergency medicine. So I think for me personally the definition is where you need the skills of an emergency medicine consultant, but I think that particularly helps you in terms of defining or deciding how an urgent care and emergency system works.
I think the doctor on my left has a follow-up.
So can I just follow up on that? I think in my own experience, it's changed now. I worked in a time when everything went through me as a GP and my own call at night and so on. And I am worried about this definition of for what a UCC does, and that having a standalone UCC, especially as I'm not sure the public understand that. Now, previously, and even now, well, I know that patients walk into my surgery with pulmonary emboli. They walk in with lower abdominal pain, and it's a query ectopic. I'm thinking of the asthma that goes off while it's waiting in your waiting room. And for those patients, may have walked in, but they go out with an ambulance. Or one case during the strikes, I had to take ectopics in the back of my car. Now, which is a very dangerous thing to do. Now, my worry is that I don't understand where the UCC place is. How is the public to do that? It might be that my colleagues in general practice have to develop an out-of-hours service that is more focused and understood. But also, I'm worried about this throwing around of this UCC term, and that might be a disaster actually, and a slow burning one.
I understand. I suppose I would come back to what you're saying, in that this already exists, that patients turn up to their general practitioner and to their practice with these conditions as well, and a system is in place to move them rapidly to hospital. And the same would be true of the urgent care centres.
We don't know that, though, do we?
Well, I'm making this assumption as we spoke to the councillor before, in terms of ensuring that there is those good links and those good transport systems between the urgent care centre and the hospital. I think it's to do with getting that localisation of services there, so that if you do have to contract the number of A&E departments, the concern is, well, where will people gain access to urgent care that they may require if the general practitioners can't provide that over a 24-hour period?
Yeah.
I'm sorry to hold this. There's two things about this localisation in my head. We heard from a speaker last week that there was no clear evidence that beyond the specific examples, centralisation really works. But then, as you said, it takes time to know, and it's got to be looked into. But when I've got these running bees in my bonnet, I look at the map and I see that the inner part of North West Thames is vastly supplied with A&E. It has St Thomas's to go to, not that far. It certainly has UCH, that's St Mary's and Chelsea and Westminster. Whereas there are small deprived areas, I accept in those areas, but the great bulk of deprivation and lack of understanding, lack of sophistication is on the western side of North West Thames. And yet it seems as though services are moving in the wrong direction. Now, surely, I just wondered what your feelings were as an emergency medicine consultant, thinking of the bigger picture, as you do, because you're a leader of that speciality, about that. I mean, common sense seems to me, sir, say move St Mary's to Ealing. Like St George's moved, or like Charing Cross moved. What's stopping that happening? It's obvious.
I understand what you're saying, and I think if you redrew a map, that you would want to not necessarily put a hospital at Ealing. It would be a hospital probably closer to other different infrastructures. You may want to build a new hospital, but obviously these things take time, and you need to look at the whole population as a whole. But that is certainly something which could be considered in terms of where those hospitals should sit and the services that they're best served with. But obviously there's political ramifications of all of those things. If you were to move hospitals out of one area into another, I'm sure that those local populations would be saying the same things.
You don't think it's due to medical politics that people don't want the hospital?
There could certainly be some medical politics as well.
I'm sorry, can I just... Just one final thing. I'm worried about what happens to this talk about so-called small local hospitals with 50 beds to care for the elderly, etc. And I put this to a medical colleague last week. I'd like to hear your views. Doesn't that mean that if you're going into so-called local hospital without any of the backup of other major hospitals, that you're already being denied full care? For example, if your pneumonia goes off.
Yes, I'm not, obviously I don't know those proposals in huge detail as to how they want to do this. That there is evidence from other countries where they have these step down and step up units, which is what I think you're referring to, whereby patients who don't need the full backup of a whole acute hospital can go to an environment where they can receive specialist rehabilitation work and a sort of an intermediate stage to going back into the community. And there's evidence that that has been very popular with patients, because otherwise they're in an acute setting, then straight back at home. Now, we know
rehabilitation is not being talked about.
No, I understand. So I'll keep going. So then we know that the hospitals, if you go round a hospital, say a percentage, and probably quite a high percentage of those patients don't necessarily need all the backup services in an acute hospital, and therefore moving those into a lower acuity hospital could be for their benefit, whereby they're not disturbed by all the other things occurring, and they can have kitchens and things where they can do things for themselves, but in a safe environment while they go back into those rehabilitations. I think that's the theory of those particular centres in terms of step down, and the idea that you have good links though back into the community, into the acute hospitals, because exactly as you say, those patients who deteriorate deserve the care even when they're in that step down environment that they would get in a larger hospital as well. And there are systems that you can build into that to ensure those occur. The other side of it is to step up, and I know from my practice in emergency medicine that I have a number of patients who I have to admit into my hospital who do not need an acute bed in terms of medical care, but they do need care in terms of social or care of their abilities of daily life, which could be better provided in the short term in that type of environment as well. So I think there's a two-edged sword, and I understand exactly what you're saying, but this is where you have to build in the networks, and you can't see these as isolated units. It's like the urgent care centres, you can't see them isolated. And that's why I think also it gets back to my comments about the funding, where the funding has to be seen at a population level. You can't see it as I'm going to fund a hospital here, an urgent care centre here, a community here, and 20 GP practices. We need to do that as a whole and make those decisions together.
Thank you.
Just very quickly, you referred to going back to those services that are proven to benefit from centralisation, and you referred to hyperacute stroke unit. I mean, you'll be familiar that Charing Cross is the leading hyperacute stroke unit in the country.
Yes.
At the present time, and yet you also realise that that's scheduled to lose those services altogether. I mean, would that fit with your kind of idea of how the centralisation should take place?
My understanding is that that's going to be moved to co-locate with the Major Trauma Centre at St Mary's, is my understanding, which would make sense because that would bring together the neurosurgical service between those two hospitals, and also the sort of imaging type service as well. So you could see quite a nice synergy between major trauma in terms of some of the backup services they require, as well as hyperacute stroke.
There's that much spare room at St Mary's site where they can just take over a large area to commandeer for that?
I'm assuming this is post all these things, and there's new buildings and other services in place. I don't believe that they're going to move those until that's occurred, from my understanding.
I suppose the reason I'm asking this is because it does seem to me that some of your points, which are general about some of these things, are readily interpreted by people who are trying to argue for these schemes as applying here, regardless of the fact that actually the circumstances on the ground may turn out to be very different. I mean, we've heard earlier evidence that in fact the footprint of the new St Mary's is going to be smaller than the present footprint, in which case it does raise the question of whether this adequate service and space could be provided in St Mary's to deliver those services. But are you concerned that sometimes you make general statements about principles, such as urgent care centres and so on, and then find that you'll be effectively misquoted somewhere else for it to mean something you didn't really mean it to mean?
I absolutely, which is why I'd always qualify those things by saying that it depends on the modelling, and it depends on ensuring that your movements of patients are following the predicted routes, so that you are making those services big enough to care for patients, which is exactly what I said in the evidence I submitted as written, is that the modelling is key, and making sure that all the services are of the right size to receive the right acuity of patients, not just patient numbers, it's also the acuity of patients that needs to be provided as well. And if those aren't in place, then you can't start altering all the systems until they are.
Thank you very much indeed.
Thank you.
Thank you.